And welcome to our South East monthly perinatal mental health webinar. Just a reminder to everybody with regards to housekeeping, please make sure that your lines are on mute and cameras are off unless you are presenting until we get to the questions bit. Please raise your hand if you want to ask a question. I think, as usual, we'll probably be quite tight for time today, so we would advise that people put questions in the chat, and then if we have time to pick them up, we will. Otherwise, we'll ask speakers to answer them within the chat. And just a reminder that the webinar is being recorded for those that aren't able to attend today. So just to make you aware of that. Okay. So our focus today is health inequalities, which, as those of you that are regular attenders will know, is a rolling theme of ours. So we will start off as usual with a quick national update and regional update from myself and Jenny, and share some of the upcoming sort of meetings and webinars that are taking place. Then we have three fantastic speakers for this morning. So we will start off with Yelena, who's going to talk about improving outcomes for perinatal mental health women from ethnic minorities. Then Amal will talk to us about FGM, and we appreciate that this contains some difficult material. So if there is anything that is shared in the presentations that is concerning or triggering, then please do notify us at the end of the webinar, and we will provide appropriate support. Then our last speaker is Victoria, who will be speaking to us about refugees and asylum seeking women. We have a very packed agenda today, so we will keep to time for our speakers, and hope to finish dead on 11:30. So just a reminder, if you're joining us now, if you could keep your lines muted and switch your cameras off unless you're presenting, that would be greatly appreciated. Thank you very much. So in terms of national and regional updates, firstly, an important announcement. So today is our 40th webinar. Since we started these webinars 3 years ago, at the very start of the pandemic. And we just wanted to announce to everybody that next month, so March's webinar, will be our final webinar. After 3 years of doing them on a monthly basis, I don't think we haven't missed a single month, and I think there's been a couple of times when we did more than one in a month. We feel it's time to come to a natural pause. But a massive thank you to all of you that have made the webinars so successful, that have either spoken on the webinars or have also attended the webinars, and in particular to my partner in crime, Jenny. It's been a fantastic thing to do with her, and those that have been behind the scenes, in the team previously, such as Yvette and Barbara. But a great piece of work, but they will sadly be coming to an end. So next month's webinar, which is on the 29th of March, will be a bit of a celebration of all the work that we've done through the LTP, kind of our rolling themes within the webinars, and then there will be the launch of our film on transgenerational trauma as well. Okay. So in terms of updates, I just wanted to update everybody. Obviously, WebBed's transferred to the capacity planning management system, but I just wanted to flag to everybody that there is a new help desk email address. So this was brought to our attention, I think, last week or the week before, that the help email address was no longer working. There is a new one, and that is the new email address. So hopefully it will have been circulated to you via other means, but just so that you have it there as well. So some different events that are coming up. I won't go through all the details, but just to let you know, so the Maternity Consortium events, the Maternity Consortium are having events to support the delivery of inclusive and accessible specialist perinatal and maternal mental health services. There are 2 free online events. The first one is taking place on Friday, the 10th of March, and the second event will take place on Wednesday, the 29th of March. There are a number of workshops to choose from within those events. You do need to register for the events, so you do need to book your place, and details are included on the slides. So just to make you aware and to go back to the slides when they come out after the webinar in order for you to enrol on that. There is also a Sequin webinar taking place on Wednesday, the 15th of March. My understanding is I haven't seen an invite as such to this, but the details are on the collaboration platform, and there is also a Teams link. So you'll get it obviously within the slide set, but also if you check on the Futures collaboration platform, that's obviously in line with this year's or this the new financial year's Sequin. So it will be a good one to attend, just an hour on the 15th of March. Okay. There is also a joint MBU and Community Perinatal Mental Health Services workshop taking place on the 22nd of March. That's between 10 and 12:45. And what they are asking for is 2 representatives from each MBU and community team, so 2 from each, to attend the event. Now, I'm sure in your individual regions, you'll be getting details directly for that in terms of invites. I know for ourselves in the South East, we're just about to send out emails to the MBUs and the community specialist teams requesting who will be attending, but information about that, so look out for it. And again, then the individuals will need to register for the workshops in order to receive the direct invites. And the work of the provider collaboratives will also be highlighted at that workshop, which will be quite important. There is a National 0 to 5's Mental Health Shared Learning event taking place on the 20th of April, 9:30 till 12. Again, you do need to register for that, but that's bringing together, in terms of updates for Start for Life, the family hubs programs, etc., and that continuum across the pathway of obviously perinatal mental health into CYP mental health. So looks like it should be a good event. And then I also wanted to flag this leadership programme opportunity that's come up. This is the Florence Nightingale Foundation funded leadership programme. This is within the South East. So I just want to make that clear. It's for South East colleagues rather than national colleagues. But it's a funded leadership programme to midwives from ethnic minority backgrounds to develop leadership presence and impact. It starts on the 21st of March, and there's a series of workshops and webinars and that over a period of 6 months. And there's contact details if you are interested in applying. So please do contact Lucy directly. But as I say, that is a South East opportunity. Okay. There is also, linking with our maternity colleagues, an invite for co-production to contribute to the development of the National Maternity Equality and Equity Workforce Report. And they're looking for people to come forward in order to run co-production sessions and focus groups, and details of getting involved are included on the slide. So very much looking for professionals and individuals, obviously with lived experience on that one. Before I hand over to Jenny, just to say, Alex, I've seen your note in terms of the email address in the chat. Whilst I'm sharing the slides, I can't add it, but I will add it into the chat at the end so that you have it. So there we go. And I'll hand over to Jenny now to take us forward.
Thank you.
Brilliant. Thanks, Liz. So I just wanted to start with a reminder for South East colleagues about the cultural competency workshop, which you can still book onto via the Perinatal Academy. There are still spaces. I know it's only next week, but I have to say we've had the best feedback for this course, and somebody actually said it was the best course on this sort of topic that they'd ever done. So there's an endorsement. So if you can, if you've got new starters or anybody that might have the capacity to be able to do it at such short notice, use up those spaces because it is a fab course. Next slide, please. And you'll probably all be fed up with this one because we've been pushing it every month. But it's the Gypsy and Traveller Cultural Awareness Training. The license actually runs out on the 28th of February. So again, last chance to get your new starters, existing staff through this. And as I've said on many an occasion, it's just 4 modules at about 15 minutes each. So thoroughly recommend that one. Can I ask people joining to switch off cameras and mute themselves? Thanks. So this is, do you know what? I've lost my thread now. This one, understanding and tackling barriers to ethnicity recording.
Do you want me to?
Can you jump in on that one, Liz? Sorry.
Yeah, very happy to. Sorry, I put this in the last minute. This was raised when I was on a national meeting yesterday. So this is a new case study about understanding and tackling barriers to ethnicity recording. So it's a case study done by Cheshire and Mersey Specialist Community Perinatal Mental Health Service. The link is there. It's on the Futures collaboration platform, but just goes through what they did in terms of tackling the barriers and ensuring, you know, greater ethnicity recording. So yeah, it's a good one, just a good resource just to go and have a look at.
Thanks for that. Sorry, I lost my way. Next one, please. So anybody that's sort of been on the journey with us will know that one of my pet hates is the poor recording of ethnicity that happens across so many of our services, and you know, and then the subsequent worry that how do you know who's underrepresented in your service if you're not recording ethnicity correctly. So this is national stats from July 2022, and you can see for yourselves that the numbers at that point was still high in terms of unrecorded, and large percentages of people recorded as other, and that does jump out to me as kind of quite lazy recording, because I'm not sure if you ask somebody, we know how they identified, what their ethnicity was, that they're going to say other as the response. So I think that's another thing that we really need to be working on. And I know that Amy from the national team has been doing a piece of work around this, which hopefully will be published soon. And then we can see what the blocks are. And I think already from Amy's work and from talking to colleagues in maternity that have done a similar piece of work, there's a big issue about staff not having the confidence to ask the question, or they're worrying that they might be asking it in an insensitive way. So it feels like what might come out of this is a bit of training, and that sounds like something that we could, you know, get our heads around and really help to improve this. Thanks, Liz. Next one, please. So this is going to lead on nicely into our first speaker. So I'm really delighted to introduce Dr. Jelena Jankovic, who has been doing a really, really interesting piece of work on improving outcomes for perinatal mental health women from ethnic minorities. So without further ado, I'm going to hand over to Jelena, and I'm really looking forward to this, Jelena. So thank you for speaking for us.
Yeah, thanks a lot for inviting me, and I'll talk on behalf of the whole PAN team. So if I could have the first slide, please. So this is the study that was funded by the NHR, and looking into improving accessibility and acceptability of perinatal mental health services for women from ethnic minority. And that's the overall aim of our PAM study. I could have the next slide, please. And the way we planned to do that was through 3 studies. So the first study that we've done was looking into linking 2 large NHS databases, and we looked at rate of access of women from different ethnic minorities to mental health services within perinatal period. And we also looked at pattern of engagement. And that study has been published in the BMC Medicine and showed quite a big discrepancy in access rate for women from ethnic minorities. Then the second study that we did was looking at a service evaluation of perinatal mental health services in Birmingham, Nottingham, and East London. So we looked at pathways to accessing mother and baby units in these areas and pathways to accessing community perinatal mental health services in Birmingham and East London. And then the third and the largest part of the study was qualitative interviews. So we've done over 100 interviews with women who've accessed perinatal mental health services, with women who had mental health problems but did not access perinatal mental health services, with family members and healthcare professionals. And just to say that study 1 and study 2 focused on women from all ethnic minorities, and for study 3 we focused on women from South Asian and Black ethnic background. So if I could have the next slide, please. This just summarizes the interview, the research questions. I think I've mentioned it for study 1 and study 2, and for study 3, so the large qualitative study, it was to explore the views and experiences of accessing perinatal mental health services. I could have the next slide, please. So this was a very large study, and we are now near the end. So given that we have 15 minutes only for presentation today, I will focus on recommendations for clinical practice that we have from results of our study. So this is this represents the journey of our study, and I just wanted to say a special thank you to our lived experience advisory panel who've been advising us throughout the study, from the initiating the study back in 2018 to now being near completion. Study 1, as I mentioned, has been published in BMC Medicine, and we've for other parts of the study, hopefully within the next 6 months, the final research data will be published. So what I'm talking about today are still emerging results. So I could have the next slide, please. This is just a note on language, because we've had, when we thought of the title, we had different ideas what to use. In the end, we went with ethnic minority because at the time that was the, what lived experience a representative that we consulted on recommended. But we fully appreciate that it's far from ideal, but that's the term that we've used for this study. And for ethnicity categories, we've used British Census data categories. So if I could have the next slide, please. Yeah, the next slide. Yeah, so I'll talk today about recommendations for clinical practice, and the way we've structured them was looking at separate recommendations for improving access to perinatal mental health services and a separate set for improving experiences. So I could have the next slide, please. So the first one may sound obvious to us working in perinatal mental health services as to what we provide. But actually, if you look at it, there has been a huge expansion of perinatal mental health services over the last, since 2016, so since 5 years overdue. And this is what's been, these are all the recommendations coming from data, in particular qualitative interviews, that actually we need to be actively providing information as to first that services exist in local area, but also what our perinatal mental health services can offer, because in most of areas we do offer quite a wide range of interventions and have rich multidisciplinary teams. So that's something that's quite important to advertise. And I think this links to the second recommendation, links to what Jenny mentioned, that we'd recommend for every local service to check really their access rate. For that, we need to use ethnic structure of local maternity population, because the difference than ethnic structure of general population. but also we do need to get better at recording ethnicity within our service. But ideally, we should be checking regularly access rate for women from different ethnic minorities by comparing access rate to our services with ethnic structure of a local maternity population, because only then, when we realize where the discrepancies are, we can put a plan in place to improve that and make services more equal, or make accessibility, improve accessibility for our services for the groups of women that don't access it at equal rates. It's important to work with local communities, so to increase awareness of what perinatal mental illness look like, and particularly there are different cultural and spiritual explanatory models for perinatal illness. So we need to work with our local communities and see how we can have that dialogue and explain what we offer for a treatment of perinatal mental illness, and also advertising what we offer in different formats and languages, working with community organizations and community leaders to see what would be the most appropriate way of explaining what we can offer, and also in particular doing it in other languages that are prevalent in our local communities. Can I have the next slide, please? A common reason that women say they have not access services is the fear that a baby will be removed. And again, this is recommendation based on what on the data from the interviews. And the recommendation is to talk about that rather to avoid it. And whilst safeguarding is an essential part of our jobs, it is important to explain what we can offer in terms of interventions and support, and also that the goal of perinatal mental health services is to support a mother and baby bond. And the recommendation 5 is to routinely and repeatedly ask about well-being and mental health in the perinatal period. So this is a recommendation really for improving access, because that's what seems to be important, not to be a one-off question during maternity or postnatal journey for women, but to ask that on repeatedly and routinely at every contact, or at least several times during pregnancy and postnatal period. And then what some of women and families told us is that for them it would be relevant information as to what do our perinatal mental health services look like in terms of professionals. So what we'd recommend is that can be information that can be shared, that perinatal professionals come from different ethnic backgrounds. Just to say, it's not that it's important for every woman and family member we spoke to in the study, but for some that was quite relevant information. If I could have the next slide, please. And also practical barriers such as lack of time and resources are very important for some women. And given that some of the results from our study, so of that study 1, do show significant discrepancy in access, we do think it's important that local services should make efforts to remove these barriers, such as help with transport and childcare, to improve accessibility of our services. So I'll move now to recommendations about improving experiences. If I could have the next slide, please. Again, the first recommendation is something that has been mentioned in other studies, but again, this is something that was an important theme in the interviews that we've done, that responsiveness, respect and kindness from staff, and also care being provided by the same person throughout where possible, is important to build and maintain trust. Also, peer support workers from ethnic minorities, so people with lived experience of perinatal mental illness, are an important part of perinatal mental health teams and help positive engagement. And that's something that we would recommend that local services consider. And there are quite a few services across the country that do have peer support workers from ethnic minorities, but it's certainly one way that can improve experiences of women based on our results. I could have the next slide, please. So in terms of communication, what we recommend is to explain first how to contact services, but also once women have had first contact, what are the timescales? So the timescales from first contact screening to the assessment, from assessment to referral, from referral to intervention. So just giving best estimate of these times does improve clarity of communication. Also, importance of communication with other services. And some people within our study did mention concerns they have about confidentiality with interpreters. So it is important to consider and again to address that as one potential factor that's quite important for engagement of women. Again, if possible, really trying to avoid cancellations. And what women mentioned is that not hearing back from services or referrals not being passed on had detrimental effect on their engagement, and clarity, honesty, and consistency being quite important. In terms of choice of appointment, it is important having choice of face-to-face or home visits or virtual visits. And then the next two recommendations are about involving families. And we know that in most of areas, there is already ongoing work linked with a long-term plan. But it's important to involve families, but also being careful not to put pressure on family members to manage risk at home that they do not feel comfortable with. And if I could have the next slide, please. And also checking well-being of the family members and offering and providing support when needed and possible. In terms of discussion about culture and I guess cultural aspects of child rearing practices, what the recommendation that we made based again on mainly qualitative interviews was to show interest and curiosity, but try and avoid assumptions when asking about culture and child rearing practices. And that unconscious assumptions related to ethnicity can occur among staff, so that it would be important to think about creating time and space for staff to reflect on their biases. And if I could have the next one, please. And when we talk to our participants in the study about importance of culture and ethnicity and talking about it, for some it wasn't as relevant as for others, but for some women it is really important. So we recommend always consider asking about culture and ethnicity, because for some women having that space to share is really important. And the last recommendation is about use of language, to try and reflect and use women's language for their experiences and ask questions and explanations about what women mean so that a shared understanding can be built. So that was a very brief overview of our recommendations. As I mentioned before, the results of all the studies and analysis of qualitative interviews will hopefully be published within next 6 months, so that you can sort of further look into that with many other quotes and really looking as to where these recommendations come from in terms of data. So that's the end of my presentation. Over to Jenny and Liz. Yes, and this is a very important slide. Talking about expert reference group that helped us with finalizing these recommendations, and PAM research team, and any colleagues who helped us come up with these results.
Thank you so much, Jelena. That's amazing. And such a sort of in-depth study. It's got some really good stuff. And I guess it's like a lot of times when we do these things, some of it seems so obvious, doesn't it, when you say it, and then other bits are like, oh yeah, I hadn't sort of considered that. So there's some great stuff in there. Did the women that sort of were part of the interviews, were they was it easy to find that audience? Did you have to sort of use different local groups and things to get participants?
So we had, so the group, we interviewed 37 women who accessed perinatal mental health services. It was a bit easier through local perinatal mental health teams to recruit them. But what we are particularly proud of is that we managed to recruit 23 women who've not accessed service, because that was, I think as clinicians speaking now, I think we know a lot about women that we work with, so who access services, and we don't know much about women that we don't see and the voices that are not heard because they've not accessed services. And we had to use a variety of different strategies through local community organizations and through social media in particular. But yeah, I'm quite pleased that we've managed to recruit those women to give their views of really experiences of, because ultimately they did not access services. Brilliant. And we had, just in terms of numbers, 15 family members and 24 healthcare professionals of different professions. So, oh yeah, over 100 interviews in total.
Fantastic. I'm afraid I've hogged the live question because we only had time for one. I've only just realised. So sorry about that. But if you're staying, Jelena, are you staying?
I apologize. I have to go to the MDT, but I will put my email address into a chat. If anybody would like to email me, please do. Thank
you so much. So without further ado, we'll move on to our next speaker. Amal Hassan has very kindly agreed to talk to us about FGM, which is a subject that we haven't gone into any detail about on previous webinars, but so important to consider. And Amal, I messaged you earlier just about, because obviously some of your content might be triggering for some of our audience potentially, and are you okay if that occurs for anyone? Can we put them in touch with you? Is that okay?
Absolutely.
Brilliant. Thank you so much. I'm going to hand over to Amal then, and just as a caveat, as Liz said at the beginning, that potentially some of Amal's content is could possibly be triggering. Okay, over to you, Amal. Thank you.
Thank you so much for having me. So I work for an organization in East London where our offices are in Tower Hamlets. It's called Women's Health and Family Services. And we actually have two major projects actually at the FGM and the Maternity Mates program. So I thought it would just be, instead of assuming that everyone's really aware of FGM, I'm just going to spend about 3 minutes just going over FGM, if that's okay. Can you go to the next slide for me? So just to define FGM, it is all procedures that involve the partial or total removal of the external genitalia or injury to the female genital organs. So whether for cultural or any other reason that is not for medical reasons, so it's not there to heal anything or fix anything, any type of injury. And I'm just gonna, if you can go to the next slide. And just to give you an estimate globally, and obviously these are always going to be estimates because of the type of practice it is and the nature of the practice. We're never going to have exact numbers because it's a hidden practice generally. And so you've got an estimated numbers from UNICEF that are 200 million girls and women who are actually living with FGM across 31 countries around the globe. And obviously with migration and movement is the reason why it's everywhere. So it's not really contained in where the practices originate from, but rather any and everywhere. Just if you can go to the next slide for me, to give you the countries that we generally see in terms of numbers. The average women that are estimated to have FGM or are living with FGM in these countries are, these are the countries that generally also that we do see in the clinic in high numbers, 99%, Somalia, Egypt, we've got Mali, those countries, but the countries that we don't have data for are things like Malaysia, Indonesia, and generally in Egyptians, you will see there's medicalized FGM and there's non-medicalized FGM. So a lot of the medicalized FGM, the young girls that we do see in the clinics that we do support from Indonesia and places like Malaysia are not even aware, and it's generally a type 1. But 3 million girls annually are still at risk. So even though there's a lot of movement to eradicate the practice, there's a huge number of girls that are at risk annually, and that's estimated at 3 million. If you can go to the next slide for me. Here, for our purposes, if you can see the NHS Digital, most of these women that are, these numbers are in obstetrics. So we've got about 30,000, over 30,000, 30,335 women that have been seen in the last 7 years between 2015 and March of 2022 that have FGM, and those are mainly from obstetrics. And we do see that in clinics for us as well because of the mandatory reporting for, not mandatory reporting in terms of the under 18, but women who are pregnant who are survivors of FGM are automatically referred for the FGM clinics to be assessed for risk assessment for their ability to deliver naturally, to understand their delivery plan, any risks that this practice might pose for their pregnancy as well as their delivery, but also to do a risk assessment for the unborn child. So that allows a good number of women to be recorded through the NHS Digital. But those who are non-pregnant really generally do come forward only based on the fact that they have complications, they're experiencing some sort of difficulty with intercourse, or they're getting married, and they found out that this might be an obstacle to their intimacy. So the non-pregnancy numbers that we do see are lower than the pregnancy numbers because of that requirement that is in place, that any woman who's a survivor of FGM be sent to the clinic to be assessed. If you can go to the next one for me. So in terms of talking, and we talked a lot about language and ethnicity, Dr. Yelna addressed the fact that it's important for some to break through some of these barriers, to have someone from the same ethnic background or using the right language. So not everyone really understands FGM when you say that, and sometimes you might have to use the local languages, such as Sunna for Auni, as well as also female circumcision, because some cultures actually refer this to the counterpart of male circumcision. So using female circumcision, or have you had anything done down there, those things will help you understand, will help the patient understand better what it is that you're referring to. But female genital mutilation might not be the right word for some women who are not well versed with that term itself. The next slide. And just to kind of give you an idea, why it's practiced, I just want you to take away that there's a huge list there, but I want you to understand that really there is no particular reason in terms of that is consistent across every culture, because the cultures that do practice FGM are varied. The religions also are varied. You have, a Christian woman who's from Sierra Leone, a Muslim woman from Somalia, and even if they're Muslim, their cultures are also different. Just because they share the same faith does not also mean that the family practices the FGM is coherent across all these cultures. So it could be anywhere from signaling a girl's become a woman to increasing a male's sexual pleasure. So whatever the reason is, it is not a one reason that this is why it occurs. It's very varied, and sometimes it's just a continuation of cultures. I've seen so many girls that say, my mom has had it, my grandmother has had it, it's just something that we do. So the next slide, if you can do the next slide for me. And ages, it's between 4 and 12 years old. So some girls might not recall they've had FGM or the experience itself. And like I said, some of the FGM is medicalized, and that might be that they're under local anesthetic, so they don't even remember. But being in labor or being examined might trigger some of those memories as well. Or they could have been really, really young, as even younger than 4. So in the UK, the first prosecution case in 2019 was a 3-year-old that presented in A&E. So just to give you an idea as well, the age is varied, and we have seen some women as well that just to fit in back home or whatever the case might be, they've asked their parents, because they've been teased or whatever the reason is, that they've asked at an older age to have FGM done to them. So that it's also varied. If you can go to the next slide for me. These are the images that Jenny's talked about as well. They are quite graphic, but they are sketches, so they're not real life images. So if anyone is triggered by that, I would just suggest you kind of, lower your screen or minimize your screen, sorry. But if you have any concerns afterwards, you can definitely get in touch and we would be happy to talk you through that. So if you can go to the next slide. So this is an FGM type 1. So this is, a lot of the certain cultures you will rarely see the other types, but you will see a type 1 where the greenish bluish area is removed. And it's the clitoris area that is removed. So this generally does not present any issues for giving birth, because what the clinic, the specialist midwife does is to make sure that there's no skin, there's nothing covering the area, and to make sure that if there's any tearing or anything that happens, it does not impact that woman's delivery. So that this generally does not present a huge issue, but obviously it still has its own complications. The next one. The next slide, sorry, I apologize. Type 2, now this could obviously present an issue for a woman who is giving birth, who wants to have a natural birth. So all that area is removed or stitched together and closed up. So there will be some skin covering the vaginal opening, and this is one of those ones where we do the defibrillation generally. And the next one is, if you can go to the next slide, is a type 3. So this is the most severe and the most complex type of FGM, both physically, and that presents the most complications for women who are giving birth. So all that area is removed, stitched together. So generally menstruation, intercourse, everything is very difficult. And these women are the girls that we do see that come even before they're getting when they're getting married, that are having menstrual issues. This is the type or type 2 that they have. So and then these are the ones that require definitely the defibrillation, where they are opened up to be able to deliver naturally, to have intercourse, and to urinate, all kinds of things that they're having difficulty with. So if you can go to the next slide. So defibrillation is the opening, and re-infibulation, which we have also seen women who have delivered naturally in their home countries or in other countries where and have been resutured, so re-infibulated, and then they've come here and they're having their second baby, and the assumption is, oh, they've had a natural childbirth. But it's important to ask if they've had that child outside or even here, if they've been re-infibulated, because that is quite common to sometimes to have that resuturing done, and obviously that is also illegal here. Even when they deliver, it's only stitched up to what is medically necessary, and if there's any tears and things like that. But it's important to also not assume that if they've had a natural birth that they have not been re-infibulated, but ask or even if the woman is comfortable enough to be examined, to re-examine that to make sure that she is able to have the type of birth that she wants to. And the next slide. And FGM type 4 is any and by definition is any and all procedures to the female genital organ. So anything else outside of those 3 types is considered a type 4, and that would include something that most people wouldn't think of, like piercing. So in the next slide. So these are the immediate complications when the actual FGM is being performed. So anything from severe bleeding, the clitoris is a very sensitive organ. Even when the defibrillation is done, until the urethra is visible, and they don't open it up all the way to the top because of the fact of that sensitivity in that area as well. Just what is necessary is where the defibrillation is done to. So you could these are all the things that can happen when the actual FGM is being performed. And if you can go to the next slide. But the long-term complications is really where we do see the patients for us as well, because we don't see immediate women who have had FGM done recently or in the last week or things like that. But we see women who are living with the practice and who've had the practice done, years ago. So the difficulty in passing urine, UTIs are quite common. Uh, you've got obviously the issues with being able to deliver naturally, a wide range of psychological issues, problems with being pregnancy, sexual dysfunctions, so not being able to feel comfortable in intercourse, not being able to have certain sensations, and things like that. So these are the long-term complications that we really address in the clinics that we support. If you can go to the next slide. And for the purpose of this, psychological complications are very common, and sometimes they don't manifest themselves until they're in that clinic. A lot of the women that we do support in these ethnic minority communities have never gone for a smear. They've never they felt that they've never been asked the question of because they're from that cultural background. We talked a lot about asking the question, and a lot of health professionals don't feel comfortable asking the question, but it is important to feel comfortable in asking that question, because patients have obviously said that I've never gone for a smear because of, I have FGM, severe FGM. So it's important to not feel uncomfortable to ask those questions, asking them to say, I understand that you're from this particular community. FGM is quite common. I want to make sure that you're not coming forward for the smear based on this. So a lot of women are the psychological issues that they have in terms of accessing support. It would really help if they've been looked at fully without feeling uncomfortable about asking those questions. So there's the emotional distress, the PTSD that sometimes, a lot of the women that the consultant spends about 45 minutes assessing their ability to even have a conversation, how they feel, their PTSD, if there's something that is there that might, create complications when they're on the table, because a lot of the women do not have never been in that position.
Sorry, can we just ask everybody to make sure they're on mute, please?
Yeah.
It was possibly Amal's something going on in the background. So, she's
Sorry,
back now.
I apologize.
No, that's fine.
So the psychological issues are quite, and because of the mandatory referral through pregnancy, they automatically are probably seeing someone about the FGM for the first time, and they're probably even coming in confronting that issue, or even learning about what this is for them. So in pregnancy is really a big part of the time that they're coming forward, because we don't, like I said, the high number of women that we do see are those that are pregnant, really thanks to that stipulation that they have to come forward. They have to come and be seen for that. So the PTSD is really quite common. The defibrillation, we don't, in case something it triggers them while they're being opened up, it's really important to assess their psychological ability to handle being defibrillated. And if that's not something that we find is feasible, they are sent for counseling. They do the counseling first, and then they get the defibrillation. But for pregnancy, obviously, there's a limited time throughout their pregnancy in which they can have the defibrillation prior to giving birth. And if they pass that time, unfortunately, it would have to be in labor that they are defibrillated. But we try our best to try and facilitate that and make sure that that referral is in early. So a lot of that is also important to make sure that that is the questions are asked at a time where it's possible for them to have more choices, and be able to go home and think about it and come forward and have the defibrillation themselves. If you can go to the next one for me. So FGM in the law, obviously, as regulated professionals, there is the responsibility, if you can go to the next one, to it is illegal. There's a mandatory reporting if you're seeing under 18s, but it's also important to know that as regulated professions, you do have the responsibility to ask those questions. And mandatory reporting is unfortunately part of that, but it's important to have a thorough conversation with the patient or the person that you're supporting to help them understand why it is that that you're doing what you're doing, and really. A lot of women, we always recommend, even when it's young people, to talk to the parents if it does not bring harm to the child, and being open and honest with them about what it is that you are also legally required to do and why it is there. So it doesn't create a lot of barriers, but for the FGM in the law, it's obviously an offense. And sorry, to also not protect a girl from FGM. And also the ability, you also have an ability to take out an FGM protection order, which allows the multi-agency hubs the MASH teams, the safeguarding hubs, to investigate. But the mandatory reporting is really where you call the police, is really when there's an immediate risk, but also you can do your internal safeguarding and have those conversations. If there is no immediate risk, you do have time to go through those things and have those conversations. If you can go to the next slide for me. And the next one, I think I covered this already. And then next one, sorry, I apologize. And like I said, Jenny and Dr. Yelena talked a lot about asking those questions and treating it like any other safeguarding issues. I cannot emphasize that. As regulated professionals, you do have a sense of responsibility, and safeguarding in any type, you're there to assess the well-being of that woman to in her pregnancy journey. So asking those questions, as long as you're coming and she understands that you're coming from a place of well-being, women are generally receptive. We found in the clinics that getting them into the clinic was very difficult when I started this job. And women would hang up the phone on you, would say, "This is my fourth child. What is it that you want?" And they were really reluctant. But once you explain to them, we're calling to make sure that, your delivery is, smooth, that you have a positive experience. We want to make sure that the FGM is not a barrier to your, to have a better labor, and things like that allows them to understand where it is that you're coming from, that it isn't a cultural attack that you're making, that you're not really, and the risk assessment for the baby is not, making her feel like she's a perpetrator. It's very important that you build those conversations around the fact that you're coming from a position of well-being. And I think being confident in the fact that that's why you're asking the questions also allows you to ask those questions directly and not feel uncomfortable about asking those questions. Being culturally appropriate and sensitive for us is really around using the right language, and understanding that when we talk to these women, which was the reason why a lot of women do not do mandatory reporting and wait until they're the 18, is that FGM, the words around abuse and violence and against women and girls and things like that culturally do not sit with the fact how they view FGM, how they view the people that have actually been that have taken them to these women or these hospitals, or these clinics to have the FGM done. Most of them will tell you that my parents are really incredibly loving people. They've done everything for me. So when I hear these things and the possible consequences that could come to my parents, I didn't feel the need to report, even though I was going through all of these things physically. So I waited until I was 18. So that language and that perspective needs to be understood by health professionals, to understand that how culturally some women view FGM and their families is not the same way that we view FGM. Being familiar with the support services is really important. So for our organization, we also deliver the maternity mates program. So the women don't just come with FGM. They are, FGM has itself complex. It's you know, it's layered. You know, they could be having intimacy relationship. Their relationship could be an issue after birth. Sex could be an issue because now this being in labor has triggered a whole lot of things. So it's important to understand their complex needs around FGM, but some of them are asylum seekers, homeless, they don't speak English. So that advocacy around being in labor and making sure that the people that are taking care of them, especially if they haven't had a defibrillation, understand that the woman has experienced FGM, to know that you know, she'll be given the defibrillation during active labor, to reassure her that, you know, everything's okay. If she's concerned about tearing, all those things are really important. And if you can go to the next slide for me, I am not sure what I am from time, but I'm going to hurry this up. So I put the link on for all the clinics around the UK, but the ones that we support are both the two clinics in East London. So that is the Primrose Clinic, which does both the Sylvia Pancras Center it's both pregnant and non-pregnant women. And the FGM clinic in Waha Clinic is based in a GP surgery, and that one is a over the age of, we only support over the age of 18, but definitely will not turn away someone who's under the age of 18, but refer them to another service. But that one is non-pregnant women only. And Dr. Yala talked about women feeling as well with cancellations, referrals, not being passed on in a certain way, things like that really can be a huge deterrent for women also with FGM. That's why these clinics that the NHS has created are holistic in terms of the way they work. If you can go to the next one for me. The next slide, sorry. So with the clinics that we work in, you've got a psychosexual counseling. WHFS does PTSD counseling in-house through our community organization. You've got the consultant, you've got the specialist midwife. So it kind of really, it takes a long time for a lot of these women to come forward or to actually be in that space. So we don't want them to retreat or to be somehow, some way, you know, not being able to in touch with the team. They get to meet everybody. There's a health advocacy, which is our organization as well. And we provide practical and emotional support. We're there throughout the whole journey. So we make sure that that woman does not fall through the cracks per se. So making sure that, and if she needs something like our maternity mates program support, we do everything. If you can go to the next slide for me. So this is the entire team. So all those services are within one space. So I think they understood that referrals can be an issue for a lot of these women, and you know, just making sure that they get the right phone call back. They're not meeting a new person that they have to explain their story to again. So this is, if you could go to the next slide for me, that was just to give you an idea of everyone that works within the clinic. And then the next one. So the women that we support, so a lot, like I said, they've come with their own you know, complex issues. So a woman who's homeless or she's got a lot of other priorities might not be able to focus on her FGM. She might have issues with counseling, the choice as well, privacy with receiving counseling. So she might not have the right space, childcare. So we make sure we have offer choice if she wants to do that counseling virtually, if she wants to come in, time of day. We offer that counseling in Arabic, French, English, Somalian, the PTSD. And so a lot of those things, you know, we try to keep as much as we possible in providing a holistic service to these women. So this is what the maternity, the type of women that the maternity mates program supports. But obviously each referral is also further assessed to make sure that it falls within the criteria, but also, you know, there might be even traumatic births. We offer also we have peer support groups for women who have miscarried, baby loss, and things like that as well. And also we do the one-to-one counseling for some of those women as well. So if you can go to the next slide. and referrals to the clinics as well as our services. So we partner, the maternity mate actually is a mate. So we partner each woman with a woman from the community, and those women are volunteers. So they actually go and support this woman and spend time with her throughout her pregnancy, 5 months onward and 5 months after she's delivered. So that support is there to allow her to connect with the babies, and we try to remove all these other barriers that are preventing her from having a good pregnancy, and as well as when she gives birth, connecting with that baby. So and if you can go to the next one, and referrals for clinic as well as our service, self-referrals, midwives, any professional can refer, community organizations, children's centers. So that referral is also, we've removed any barriers that you don't need to go to your GP and to get a referral, including the clinics, the FGM clinics, because that's also a problem for that. We found that some women are, have an issue with barriers, so they can actually go on the NHS website for the FGM clinics and email the clinics that they want. Some of them just prefer to go outside of town, outside of borough. So that is also acceptable too, for whatever reason. We try and make sure that we prioritize them accessing service and getting the whatever their needs are, as opposed to creating all these barriers as to how they get referred. And if you can go to the next slide for me, and I think I am done actually. I hope I didn't talk too fast.
No, that was amazing. Thank you so much. We've had a great question in the chat from Claire, who unfortunately had to leave us. We always lose a few people at 11. And then we do have time for 1 or 2 questions from the audience, if anybody would like to raise one. So I could just read out Claire's question to you. She's saying, have we developed any FGM sensitive interpreter services in systems? As a midwife, I recall asking the questions, but not feeling confident that the question was asked in the same depth. So just wondered, because she's saying that was going back a while, 2014 to 16, and has that been developed at all?
I am not aware of actual systems for interpretation. I know that we try to make sure that our interpreting is done face to face, and Dr. Yelena really hit great points that we do experience in terms of when someone's on the phone, interpreting is quite complicated. Some women we offer them to bring in someone they feel comfortable with into the clinics and things like that, but I don't know if there's a system specific for FGM in terms of the interpreting. And I think the other question was a second question for Claire. Was it 2 separate questions about asking?
I don't. Oh, she says, as a midwife, I recall asking the question, but not feeling confident the question was asked in the same depth.
I think a lot of GPs feel that way, and a lot of health professionals, when we do these trainings, will say that they don't feel comfortable in asking in the same depth. But I think the more you're aware of the services, I think it has to do a lot with making sure they know the referral pathways. Even if you can ask the question and then pass on the referral to the right people. So that is, and just letting them know, I'm going to refer you to this clinic, I'm going to refer you to this space. There are specialists in this area. You'll be examined, you'll get this. So I think it had to do a lot with not knowing the right referral pathways. What are the right resources that are available? I think that gives you confidence, because the GPs don't really deal with, the gynae stuff or the FGM examination. So referring them to the right places really gives the confidence to actually send them to the right space. Yeah. So I think we work really hard to making sure that everyone knows the referral pathways, and that creates a sense of confidence.
Okay, and we've got probably our last question, which is actually from our next speaker. So hi, Vicky.
Yeah, I'll carry some of this on in a minute, actually.
Yeah.
Some of these points.
Brilliant.
It's just going back to Claire's question, is I think Claire was not necessarily as a professional that she didn't have the depth for the question. I think it was the confidence in the interpreter asking the question, translating it in the depth that it was asked. And I think that's why she's saying about specialist interpreter services for really complex and sensitive issues, is sometimes the interpreter may change what you've said if it's not an area they feel comfortable with. So I think that's probably what she's driving at.
And I think that's something that we all need to be aware of when we're using interpreters, no matter what the subject is that we might want to do training with them ahead of it, or we might just want to have a conversation. But particularly for myself working in the field of mental health, I want to know exactly what that person has said to you. Do you know what I mean? I don't want anybody to try and translate it. I just want you to tell me what's been said. So I think we need to be working quite intelligently with our interpreting services to make sure we get the best out of them. And there's another hand up, and Liz will be very cross, but if it's a quick one, I'll take it.
It's okay. Go for the last hand.
Hi.
Hi, it's a quick one. It's a question for Amal. I'm lead for this mental health and FGM. I see FGM ladies. Because I've recently started, I don't know how to submit the data of these women on that national. So that was my question. Do I need to make an account? How do I do that? Because I'm trying to streamline all my clinics.
Is that for the NHS Digital?
Yes.
I can get you, because for us as a community organization, even though I do have like an honorary contract within the NHS to collect that data, we don't collect clinical data, but I can definitely, if you can just, I don't know if our emails are all shared, I can get you in contact with the clinic leads, and they would be able to definitely let you know where to. Yes.
That would be great. Thank you so much. That was a quick one.
I'll send that to Jenny for you.
Thank you.
So I can remember.
Shall I put my email here?
Yes,
on the chat.
That's actually better. Okay, yes, sorry, bother Jenny.
Thank you.
Pop it there.
Thank you.
And Amal, thank you so much. And there's loads of positive feedback in the chat. So your talk's been really well received.
Thank you for having me.
And I'm going to move on now to our final speaker of the day, another subject that's so important for us in the field of perinatal mental health, and that's the situation of our asylum seekers. So without further ado, I shall hand you over to Vicky. Thank you so much, Vicky.
Vicky, you're on mute.
That's a good start, isn't it? So I'm mindful of time, so I will try and get through these for you quite quickly.
That's £1 in the charity box, Vicky.
First one of the day. So I'm the head of safeguarding in the South East regional team, and I'm also the co-chair of the safeguarding subgroup of the National Asylum Seeker Health Steering Group, which is not really a catchy title, but we will proceed. Next slide, please. So just to touch quickly before we talk about perinatal mental health, is asylum seekers and other vulnerable migrants as a group, is we're looking at the pre-migration harm, the harm that happens on journeys to destinations, and then that post-migration harm, and then equaling that is the cumulative harm we see arriving where we see people in the hotels and other accommodation. So the vulnerability of people pre-migration and during their journeys, we're very much looking at exploitation, people experiencing multiple forms of exploitation, slavery and trafficking. Particularly women and girls are trafficked for things like domestic servitude, financial exploitation, that's particularly in relation sometimes to things like child benefit, sexual exploitation and other forms of forced labour. The pregnancies that these women and girls may experience, some of these may be as the result of rapes and another sort of sexual violence that they don't have experienced. Forced marriage and FGM are fairly commonplace, and you've just had quite an in-depth webinar there about FGM. And some of these women may have disabilities, and they may be disabilities that they've learnt to conceal as well, due to sort of prejudice against protected characteristics. They may also have witnessed or experienced, as I say, sexual assaults and rapes, domestic abuse, but also loss of family members. Those family members may have disappeared, they may have been murdered, and also for those women and girls as well, they'll experience that loss of protection as well if they're fathers, brothers, partners, etc. And they may have experienced community violence in the forms of things like war, conflicts, and persecution of people with protected characteristics such as LGBTQ, for example. State torture and persecution may not be uncommon for people in the areas they've travelled from. Next slide, please. So in a post-migration context, we're really looking at the risks then that arising from continued poverty and poor health, language and cultural barriers, isolation. So when people arrive into this country and then they go into the holding accommodation, initial and contingent accommodation that's backed up as a result of COVID, where people have not been able to be dispersed into accommodation in the way that was happening pre-COVID, and also the increase in numbers of people arriving means that they're housed in hotels. Particularly, we have quite a large concentration of hotel accommodation across the southeast. And there's a real sense of isolation and a total lack of meaningful activity that some people will experience in those hotels, which really impacts on mental health. That loss of identity, of agency, of your personal autonomy. When you're in the asylum system, there's all that uncertainty and that loss of control over your own sort of destiny, really, because you're reliant on this asylum process and all that uncertainty that goes around it. It can be really difficult to access treatment and care when you're in a new country, and it's a complex system to navigate, and you're also in the asylum system and in the hotels, so it can be really difficult for people to access treatment and care that they need. Pregnancy is commonplace amongst the women and older girls who are arriving, and there may be also continuing threats of sort of fear and threats, including debt bondage. As I explained before, things like child benefit. You may have a debt bondage that's come with you on your journey that you are beholden to for people who you've left behind at home, may be harmed if you don't pay back a perceived debt or a debt that you've incurred as you've made your migration journey. Juju as well, like a witchcraft, you may feel that you have to then go and meet up with traffickers because you're under that sort of fear of persecution because of all of these sort of coercive control mechanisms that are put around people. So there's a real difficulty in forming relationships, so that some people may overtrust, but quite often we see they will really undertrust and distrust people who are attached to sort of particularly government agencies. Ongoing medical concerns and really uncertain histories. So it is really complicated sometimes to try and get a history from somebody who's been through this kind of complex trauma in this journey. And some of the third sector organisations we work with who are very expert in supporting victims of torture, for example, will say from a medical point of view, sometimes you just need to go with what's in front of you and deal and kind of focus on developing a relationship and getting a history along the way. And looking at things like complex post-traumatic stress disorder as well. Next slide, please. So not all asylum seekers will have that kind of long-lasting physical or psychological harm, but many people, as I say, may have endured real significant trauma. And what we know of trauma, particularly complex trauma, is it can change how people think and how the brain's ability to sort of store and make memories and experience healthy attachments and develop trusts and things, that can be really significant in terms of pregnancy and birth and how people form those attachments to their babies based on what they've been through with all of that trauma. And we're also very conscious of the vicarious trauma for staff and volunteers who, while they may be used to dealing with lots of difficult and complex issues when they're dealing with citizen women and families, but actually the traumas and the experiences of people who've come from other countries, particularly ones that are in conflict zones and things, it's different, and there's sort of very new things that that workers, professionals will be hearing, and that's really difficult for them. So we need to really support and make sure there's good supervision in place for our staff and volunteers. Next slide, please. FGM, I'm not going to focus on this slide because Amal has obviously covered that really expertly, but the one bit I will go back to is I shared with Jenny some easy read information produced by our London colleagues that is really, really good. We have to remember that in translated materials, and I have got a resource slide at the end, things like Doctors of the World, is that some women and girls will not have had access to education in the countries that they've travelled from, so their literacy levels are affected. So easy read materials for accessible information can be really helpful, as are things like animations, which our London colleagues have made some animations, and I've put the links on this slide for you. Just to build on what Amal was saying as well, is virginity testing and hymenoplasty are now also illegal under the Health and Care Act. So we need to be really clear on that. And treat that in the same way. Make sure you speak to your safeguarding lead if you're concerned about FGM or you're concerned about virginity testing and hymenoplasty. It is illegal in this country now to carry out, offer, aid or abet any kind of virginity testing or hymenoplasty in any part of the UK. And it's really important that we follow local multi-agency policies and procedures like we would for any other safeguarding issue. So these are real part of violence and oppression against women and girls. So next slide, please. So key maternity issues, gosh, that's a very tiny bit of writing, isn't it? I'm just going to move back so I can see my bigger screen here. So a lot of the women and girls who've travelled, they will not have had any, they will have little or no antenatal care. So some women may present in the hospital actually in labour, and that's the first time you will have met them. And I know from speaking to midwives, that's quite a traumatic experience that they've had as well, and not been able to get an interpreter in time and just been supporting somebody that they just know nothing about. As I say, the rape and sexual violence may have been involved be the result of these pregnancies. And the women are very vulnerable, pregnant or after pregnancy, to re-victimisation, slavery and trafficking, because they're in such a vulnerable position. And sadly, we have had child safeguarding practice reviews of babies who have been killed, where their mothers have been working illegally into sort of modern slavery, into a nail bar, for example, and they've left their baby with somebody because they've gone to earn some more money. And that baby has been killed by the person that they've left it with. So there's some really horrific examples of the kind of exploitation these women are vulnerable to. Transport to appointments is a real issue, and I would urge you to your local multi-agency meetings that are set up in each area, in each ICB area around the hotel estate. If there are issues around transport for women to get to consultant appointments, midwifery appointments, GP appointments, that we're escalating those at those meetings so that they can be managed and sort of dealt with by the housing providers that the Home Office contract. As I say, availability of interpreters and translated materials just need that extra thought of the lens of forced migration on them, that there may be literacy issues there. There's frequent moves, and as a result of that, there's duplication of NHS numbers. There can be a lack of continuity of care. There are rules, protocols in place from the Home Office around the movement of women during the perinatal period. So again, if you have concerns about pregnant women being moved, again, make sure you escalate those through that multi-agency meeting so that they can be managed. Speak to your safeguarding leads if you're unsure of who attends those in your ICB. And handheld records can be really useful and actually really valued by these women. And I know that flies in the face of all our digitalisation, but actually when we're talking about health inequalities, we do have to think differently about what suits a particular group. Again, the trauma can affect the ability to remember the birth and the attachment. I've had examples shared with me of women who've moved out of the southeast hotels and into dispersal accommodation elsewhere in the country, who report that they literally do not remember giving birth because they were in such a state of crisis when they arrived in the southeast. So there's something there about the journaling, sort of memory boxes, those kinds of things that help women with their attachment. Safe sleeping arrangements in the hotels are quite often raised by health visitors and midwives as well. And again, if you're concerned about the sleeping arrangements for a new baby or a baby that's coming, make sure that they are raised again through that multi-agency meeting so that they can be addressed. Domestic abuse can be prevalent in the hotels, as is sexual safety concerns. And again, it is about making sure that you follow the normal multi-agency safeguarding procedures if you're concerned about an adult or a child that you would do for a citizen person. Don't obviously assume that someone else is making the referral. You've still got your registrant responsibilities to raise a concern. The more concerns that are raised, the better. So it doesn't matter if 3 or 4 other people have put the same referral in, you make sure you put yours in too. Registering the births have been a real concern as well, just about accessing the registration process, making sure that interpreters are booked. We've had reports of women who have travelled and gone to their appointment to register the birth and the interpreter's not been there, and then the registrar is not keen to go ahead with the process. And so there's all these real issues about registering births as well. So in your ICBs, there's those thoughts, discussions with local authorities, etc., about what the arrangements are for registration of births in your area. And also reminding women that they need to hold back £11 from their £300 maternity grant if they want to get their birth certificate paid for as well, because that's another thing that women don't always factor in. And there's lots of barriers to disclosure of abuse amongst asylum-seeking women and girls, and one of those is real fear that if you share a concern that you're being sexually abused, or somebody is hassling you, or something is happening to you, you're being beaten, abused or exploited in any way, that it's going to jeopardise their asylum claim. So we've got this additional barrier. It's hard enough for citizen women sometimes to disclose abuse and neglect and exploitation, but with these women as well, they've got that additional fear that actually they're going to get deported if they're seen to be problematic to the system. So we really need to break through those concerns. Next slide, please. I need to speed up, don't I? So for perinatal mental health, the systematic reviews are very clear that women who are asylum-seeking women will have poorer outcomes than people who are not migrant women, who are citizen women, and that mental health disorders are much more frequent in that population, particularly with postnatal depression. And the themes that come out of the systematic reviews of the literature will focus on things like stress, and support for those women, adjustments to the host country that they're in, which is not surprising, the pregnancy care and support for feeding, and their health status and history and sort of socio-demographics. That really comes out quite strongly, along with concerns around sexual assaults and unwanted pregnancies, FGM, infectious diseases. We've got a lot of prevalence of things like scabies, TB, diphtheria, and as I said, those mental health issues as well. But the women will quite often be in poor health, and access to nutritious food that they enjoy as well is really problematic across the hotel estate. Next slide, please. I think we're nearly done. So good practice examples. So we're seeing some really good practice, and particularly in Surrey, for example, we've seen they have commissioned things like the Happy Baby community that is working with asylum-seeking women. They have an equity midwife. We've seen examples in Bob of homeless and inclusion health visitors that are visiting citizen women in temporary accommodation, but also asylum-seeking women in the hotels as well, and helping them with their babies. Also, these reviewing your accessible information, as I've said, about taking into account literacy levels and sort of easy read formats, pictorial things that are in animation or podcast type formats. Opportunities for cultural exchange. So we've had a lot of feedback from our third sector partners in other areas, particularly in London as well, about the difference it makes to just have a room with some chairs and the ability to make some food that means something to you, and how powerful that can be in terms of people connecting and sharing and kind of really addressing some problems that are not necessarily clinically mental health issues to deal with. They're more about friendship and contact and feeling supported. And we know after the Grenfell fire, for example, community kitchens made a massive difference to those people who are in temporary accommodation, so they could cook their own food, connect with their communities, and sort of get that community support going. And I know in some of our areas, they're looking at community kitchens for asylum seeking women, which is fantastic. Escalating concerns, as I've said, at your multi-agency meetings, please do escalate concerns about safe sleeping, nutrition, transport, accommodation, sexual safety, anything like that. And as I say, do make sure that you follow your normal multi-agency safeguarding procedures at place as you would for citizens. And any doubts, concerns, anything you're not sure about, speak to your safeguarding lead in the provider or in your ICB, one of your designated professionals. Next slide, please. So National Asylum Seeker Health Steering Group has got several subgroups. Maternity is one of those, safeguarding is one of those, mental health is one of those. It's been running for about a year now, and we're really starting to work now on having a web page with some updates on there of what's happening in these groups, because I don't think it's very well known and we really need to publicise that. So I think that's pretty much it, and I'm happy to take any questions or comments.
Fantastic. Thank you so much, Vicky. So much brilliant information there. And again, I'm hearing like how the simple things make such a difference, you know, the community kitchens and things, accessible information. I think that's something that we can all really have a think about as well across our services. So we do have time for a question or possibly two, if anybody's got anything that they want to raise with Vicky. This is where they all go really quiet on me, Vicky.
That's okay, don't worry. It's a lot to take in as well, isn't it?
We've got one from Amal. Thank you, Amal.
Vicky, that was really good, and I just cannot emphasize what you've said about putting in your concerns and how important that is. We work closely with these women, and it's sad that as caseworkers, sometimes we have to depend on other people doing their work. So when we hold someone accountable and it's a combined concern from multiple agencies, it really helps in highlighting that and holding those people in charge of these caseworks to really step it up. So that is so important. Thank you so much for mentioning that. Thank you, Vicky.
Thanks.
And I think you'll all share my thoughts that today's speakers have been absolutely amazing. And do remember, everybody, that these are all recorded. They're put on the website. Anyone that's attended will get a copy of the recording. So do use them as a resource, because all of the information from this morning is so important to get out to as many people as we possibly can. So that's your job now, everyone on the call, to get out there and spread the word. And I'm just going to hand back to Liz now. I'm going to say massive thank you to Vicky, and I'm going to hand back to Liz just to finish off the day for us.
Definitely. Thank you. As Jenny said, amazing speakers today, as always. Such informative presentations and such important information for us to share. So sorry, there is additional resources there from Vicky. Obviously, you'll have all the slides that we'll send out, and we'll also attach the resources that Vicky talked about as well. So just to finish off, to remind you that the final webinar is on Wednesday, the 29th of March. That will be our next webinar, but our final webinar. So the focus, we've called it webinar finale. It's going to be sort of a wrap up, a kind of review of the LTP, where we've got to, also the launch, as I said, of our transgenerational trauma film, and an opportunity to kind of get together for one final time. So we hope to see as many of you as possible at the webinar in March. And just to say, wish everybody a good rest of day. You've got 2 minutes back before your next meeting. Thanks, guys, and we'll see you next time. Bye-bye.